It's really a pleasure to give a talk today about establishing cohort studies in the Global South. So I'm trying to link my nutrition science and epidemiology background today with some of the activities that might be of interest also for this very interdisciplinary audience here. And I'm hoping to give some insights about the experiences that we've been able to gain from the beautiful country of Ghana. So just briefly outlining what this talk will be all about, the next 30 minutes. First, I thought it might be helpful to do a little bit of recap of what cohort studies are and how they are positioned within the epidemiological study designs, because they are quite often exchanged or mixed with other types of study designs, just as depicted here by this small image from one of the famous Asterix comics. The word cohort actually comes from this kind of Roman word, which just describes a group of populations. And that's why it's quite often used for any type of study population in epidemiological studies. But we will look into what exactly a cohort is and why we should use this term specifically only for a certain type of studies. I then thought maybe it's helpful to give a brief overview of different types of cohort studies that we find in sub-Saharan Africa before I show you some examples of what we are currently trying to do to establish a multi-center cohort study in Ghana, before then finally wrapping up and concluding. So just as a little bit of background information and going back to epidemiological study designs, usually we do differentiate between observational designs here on the left side, as well as intervention designs, or some people also call them experimental designs. And then again, we can also divide those into group level data study designs as well as individual level data study designs. So let me see if you see my pointer here, what most people and also researchers know very well are the observational study designs using individual data. Most of our master's students or even PhD students, they have very good knowledge and experience in working with cross-sectional designs. Some have also gained experience in case control designs. What we will look at today are cohort studies. And just to remind us all about the hierarchy of evidence from those different types of epidemiological study designs, the cohort studies, they mainly rank on the top of the hierarchical evidence pyramid here. And we will talk a little bit about why this is the case. So obviously intervention studies, particularly the randomized control trials, they rank a little bit higher due to their possibility to avoid confounding, which is often a big challenge in observational studies. And then obviously on the top, we have systematic literature reviews with meta-analysis that are combining different evidence from different intervention studies, but sometimes also cohort studies. So we can actually draw a line here looking at observational studies, which are rather on the bottom of this pyramid, as compared to intervention studies and their systematic reviews and meta-analysis, which are ranking highest here when it comes to the hierarchy of epidemiological evidence. While this is quite an old overview of different epidemiological study designs, I still find this very helpful because it shows just on one slide where the main differences are between cross-sectional designs that you find in the middle here, because we do assess exposure and outcome at the same point in time. Then we also have case control designs here where we start our study with the outcome assessment and then going back in time trying to identify how people with different outcomes have been possibly differently exposed in the past, and then from that generate relationships and associations. And it also shows cohort studies and intervention studies where we start with the exposure assessment at different degrees at a continuum, or just as simple as here, exposed and non-exposed, and then trying to see how these people develop in the future the outcomes of interest. So this is what we are going to look at today, cohort studies. And just as in cohort studies, experimental studies are nothing really different. The only difference here is that we, as the researchers, are going to assign the exposure. So that's the big difference here. Observational is a cohort study, and experimental are all types of interventions. So how do we run cohort studies? What are their characteristics? Some people also call them follow-up studies, because we do follow individuals over time. And these are people who are initially free from the outcome of interest. So in most cases, that is a certain disease that we are interested in. This means we can measure the incidence of this outcome, or ideally even several outcomes. That is usually done in all-day practice nowadays. And it's important here that we can determine the exposure before the outcome actually develops. So that's why cohort studies are super helpful when thinking about causality, because that goes a big step beyond many other observational study designs, as we can be very sure that we have determined the potential risk factor of interest before the outcome has occurred. So we have this temporal relationship, which is an important criterion for potential causality. If we want to use our resources best in cohort studies, we obviously want to not only look at the overall incidence, so looking at a cohort study as a descriptive study design, but we ideally want to compare incidence of different outcomes between exposed and unexposed study participants. And this is then our analytical study design. So again, just in a different way of how to show this, we obviously start with our population of interest here, and then classify our individuals into exposed and unexposed study participants. That sounds easy, but in some cases, such as dietary practices, for instance, you can imagine that you rather look at a continuum. So for instance, people who have a high adherence to a healthy diet regimen, or a low adherence to a healthy diet regimen. We will then look over time, and that's why they are called follow-up studies, how these individuals are developing the outcome of interest. So there will be some proportion of people who will develop the outcome of interest in the exposed group. Some will not develop this outcome. And the same will also happen for individuals in the unexposed group. Some will develop the outcome, others won't. And through the comparison of these different incidences in the two groups, we will be able to calculate relative risks or risk ratios. That's what you commonly find in the literature, which will then give us the ultimate assessment and determination of the risk of individuals in relation of exposed and unexposed. Just a brief recap of prospective versus retrospective cohort studies, which you may sometimes find in the literature. When we talk about prospective cohort studies, we mean that we, as the investigators, as the researchers, start at the same point in time to collect information about the exposure, just as we enroll our study participants. So the recruitment is what we as the examiners, as the researchers, start together with, and then we follow our participants up over time. Now, this is not very different from a retrospective cohort study. The only difference here is that we will already have information about the exposure in the past and how these individuals developed the outcome or did not develop the outcome. So it's just the time point of observation which is different, but is not the sequence of exposure and outcome. So that is important to keep in mind. That's why retrospective cohort studies are quite often studies that rely on routinely collected data, such as hospital records, for instance. Now, obviously, cohort studies do have their advantages, but also some disadvantages, as you can imagine. I already talked about the correct temporal relationship of exposure and outcome, so that's clearly a major advantage of a cohort study as compared to other observational studies. We do have an unbiased exposure, which means that participants are not prone to give different answers or will be differently assessed due to their outcome status because the outcome is yet to be developed. We always start with individuals who are free of the outcome of interest. And that's why we can measure our exposure in an unbiased way. Cohort studies are also very helpful for rare exposures. So if you think about environmental exposures, such as at the workplace, those kind of studies have actually started among workers who were exposed to specific contaminants or pollutants in their workplace environment, for instance. I already mentioned you can determine the incidence, so that means how many episodes of a certain condition will occur over time, and you can precisely determine how many individuals will develop a certain outcome of interest over time. So that's why you can quantify the risk of an exposure in the exposed and unexposed group. And obviously, this is also very helpful for hypotheses that you want to test, which are unethical to be tested in intervention studies. So in nutrition science, you can think about, for instance, some hypothesis where you believe a certain dietary exposure is unbeneficial or harmful. You might not be able to test that in an intervention trial. So you will not ask people to have 4 weeks long only red meat on their plate and then have a comparison group which rather has a healthy dietary regimen. That is clearly unethical, but you can look at these different exposure gradients in a cohort study. Still, we have to keep the advantages in mind. You can imagine that particularly for chronic conditions or diseases that have quite a long lag time until they develop, you need a long breath. So the duration of cohort studies can be quite substantial, and that obviously makes it very cost as well as staff intensive. You need a lot of people who follow up on your study participants, make sure you keep them engaged, make sure attrition rates are low. This is also why they are not very useful for rare diseases, because you will need a very large study population and a very long duration of your project if you want to be sure that the disease of interest really develops. So this is rather useful for rare exposures, but not for rare diseases. Repeated measurements are often a challenge. Maybe we shouldn't call it disadvantage. We do this regularly, but obviously that also increases the costs. And it's still not quite clear how you actually model repeated measurements of exposure in a cohort study. What we call here third factors are the confounders. So again, this is an issue that in all observational projects and epidemiological study designs is a problem. So you will never be able to rule out all potential confounding factors that may disturb the relationship between the exposure and the outcome. But you can, of course, try to assess as good as possible right at the start to be able to account for that. And obviously the major challenge, and that's also what we are going to talk about today, is the loss to follow up in cohort studies. You need to really make sure that you keep your participants happy and in regular contact to continue those regular follow-ups to identify the potential outcome that will occur in the future. So this leads me to projects that have already been conducted, and today we want to look into the Global South. There's a multitude of cohort projects in the Global North, but this is not the case for places like Sub-Saharan Africa. So this data is from a review of 2011, where the investigators wanted to compile information about birth cohort studies that exist in Sub-Saharan Africa. Now, why birth cohorts? On the one hand, child health is still one of the major public health issues in sub-Saharan Africa. And that's why it's so important to look into birth cohorts, because these are the vulnerable groups. At the same time, we also know that what happens during childhood, during pregnancy, or even before gestation is a very strong risk factor for all sorts of chronic, but also other conditions later in life. So robust birth cohorts can really give us good insights into the etiology of different non-communicable diseases. Here, the authors have put together 124 birth cohort studies from sub-Saharan Africa, and you can see that most of them were conducted in South Africa or in Kenya, a few here in Ghana and in some other parts of Eastern Africa. But you can also see here that only 28 are actually suitable for genetic studies. So that means only 28 have been able to collect biological samples or even do a robust biobanking. The table here also indicates that the duration of follow-up is rather short. So what we hope to look into, that we can follow up individuals from birth or from conception up until they grow adults is very rare. So we rather have only up to 6 months or a bit more. And also the settings are very diverse, as well as the specific population groups. And here you can also see where the interest lies. It's still mainly in undernutrition of children, as well as infectious diseases. Now, over the past years, there have also been a major interest in looking at cardiovascular diseases and cohort studies to be established in adulthood. And here, André Pascal Kengne and his team try to compile information and existing evidence about cohort studies for cardiovascular diseases in sub-Saharan Africa. We have only 41, and you can see that more than half of those were based on routine data. So what we have previously called a retrospective cohort study. Again, here the duration of follow-up is very diverse, and only few studies have a duration of more than 10 years of follow-up. The same is true for the tracing, or what we called attrition here. The average attrition proportion is 70, not attrition, the trace proportion is 72%, and you can see that it ranges from 64 to 80% here in those countries. And last but not least, in the recent years, there was another review trying to synthesize information about cohort studies for non-communicable diseases. And you see that there seem to be some studies that have run out of funding, because now we only look at 30 projects anymore, while on the previous slide there were more than 40. So it means some of them have died, because that number should actually be larger if you think about cardiovascular diseases just as one form of NCDs. However, the picture is very similar. So again, it seems some projects in South Africa have survived, and new initiatives have started in Uganda here. So these are the main countries where cohort studies for NCDs are existing. But again, they seem to be quite young. So most of them have a duration of only 1 to 2 years, or maximum 5 years. And again, we have challenges here with respect to biobanking and storage of biological samples. So the issues with cohort studies and their establishment in sub-Saharan Africa, just as in many other places of the world, is the loss to follow-up, which will create selection bias, obviously. So we will not know, are these individuals who are not included in the project anymore, who did not come for the follow-up examinations, why did they not come? Is this maybe due to their exposure? And that creates obviously a big bias in the analysis of the data. The additional challenge in sub-Saharan Africa is not only human mobility. So we know that within countries, individual populations are highly mobile, whether it's due to seasonal migration, work-related, whether it's climate change-related migration or forced migration due to conflicts and wars. But we also have very simple challenges, which may look simple, but are actually complex to address. In many countries, we don't have regular addresses like street names and house numbers, but we have to rely on geopositioning system information, which is not everywhere available and can make your project quite costly. So we have to kind of work with incentives to make sure that our study participants remain with us in the study. And that can include very simple things like just soap and a package of biscuits. But most of the time, you also have to consider additional costs like treatment, medication, transportation costs, and many more. So that makes it quite difficult to establish, but also to maintain a cohort study in sub-Saharan Africa. We already touched on the issue of biobanking. Obviously, when you invest that much effort into establishing a long-term follow-up project, you may want to get the most out of it. So the willingness to donate biological samples and to identify that willingness as early as possible and keep this willingness up is very important. However, we still have infrastructural challenges in establishing biobanks in sub-Saharan Africa. So most of the time we have to think about how do we ship the samples to a central place, either in the country where we work or even to the European Union, where infrastructure might still be better. And that also explains why we see most of the cohort studies being established and maintained in South Africa, Kenya, and Uganda, because these are simply quite stable economies, and they do have the infrastructures that are needed for this kind of endeavor. Talking about the loss to follow up, we also need to consider who are the contact persons, and that's not only important for keeping people within the study, but also how do we assess our data. In Europe, it is already quite normal and convention that you can do telephone interviews or self-administered questionnaires and interviews via even online surveys and platforms. However, that is not guaranteed in many of the countries where internet connection is unstable or not available. And the same applies to the staff that needs to be thoroughly trained and retrained and rebriefed on different interviewer techniques and methods. So even though despite all the challenges, we are trying to start this kind of endeavor also in one of our partner countries, and this is what I would like to talk about in the next couple of minutes. Here you see the map, the country map of Ghana, and the 3 study sites where we want to try and establish a cohort study. You can see in the table here that we already had contact with all these 3 study sites about 20 years ago. The idea is that we would like to re-invite study participants who have participated when they were babies in a randomized control trial on intermittent preventive treatment of malaria in infancy. So they were initially randomized for either receiving a malaria prophylaxis at the age of 3 months or not receiving this prophylaxis, getting a placebo. You can see that the intervention schedule was very similar across these 3 sites, and that all the sites also were malaria endemic areas. So at that time, we were only interested in the protective efficacy of the malaria prophylaxis, which you see here in the last line. But now we are interested in establishing this cohort basically as a model for NCD-related cohorts and nutrition epidemiology cohorts. But of course, we are also interested in linking their previous malaria exposure to current dietary practices and cardiometabolic health. So the idea behind this is that we want to follow the Barker and Hales hypothesis, which states that intrauterine environments can determine your dietary practices, but also other conditions such as diabetes, hypertension, and cardiovascular disease. Now, this is not something very novel when you think about undernutrition. It has been very well established that women who are exposed to famine during pregnancy or just before conception, that their children have a higher risk of developing these NCDs later in life. But it's up to now unclear which role malaria or other infectious diseases can play in this kind of question. We have tried to summarize here, based on a systematic review, 3 potential pathways how malaria in pregnancy and early life could be related and could be a risk factor for dietary practices and also NCDs later in life. On the one hand, this could be mediated through brain development and epigenetic processes. Secondly, changes in the gut microbiome of the baby could play a role here in the programming of appetite and food preferences, as well as the direct contributions and effects that cytokines and other inflammatory markers specific to malaria infection can play here. And indeed, in a very small birth cohort, and you see the numbers here, we have been able to show that those children whose mothers were not infected with malaria at delivery, as compared to those whose mothers had an infection, had about 0.2 higher millimole per liter fasting glucose, and that was seen in Agogo, so the central area of Ghana. Now, obviously, this is only hypothesis generating, and that's why also we did this systematic review to see what kind of factors could play a role. But now this larger birth cohort could maybe help us to disentangle and verify that hypothesis. So in the cohort that we want to establish, we try to answer 3 main objectives here. On the one hand, we want to characterize the dietary profile and the cardiometabolic traits of these young adolescents or young adults who were recruited as babies. We want to define relationships between their early life malaria exposure and then later dietary habits and cardiometabolic profile. And we also want to understand how other environmental factors are driving dietary habits and cardiometabolic diseases. And such environmental factors could be mycotoxin exposure or infectious disease exposure other than malaria during their early life. Now, how do we do this? I already mentioned that there are 3 sites we want to look at. We already started in Tamale. This is in northern Ghana in the year 2023. And we started with a small pilot study trying to see if we can actually retrieve the former study participants. So what we had was the participant files with the former addresses, and the addresses were not street numbers and street names and house numbers, but they were something like opposite the filling station or behind the barber shop or friend of Kwesi Nana. And these were the addresses that we had. So we went with these former participant files and the addresses, and indeed were able to get almost half of the former study participants from this area. After we've seen, okay, it is possible, and also the proportion of individuals who were in the intervention and the control group seemed to be quite balanced, we thought, okay, we can increase that and also include the other 2 study sites. So this year we started to also roll this out in Agogo, where we had a little bit of a different approach. Here also we did have participant files, but even better, we still had contact to the former field workers who 20 years ago already recruited the study participants, so they're mothers of those former babies. And also here, we now got a bit more than half of the former study participants and retrieved them and enrolled them in the follow-up. Now in Navrongo, which is the far north of this country, this was by far the largest study 20 years ago. And this site has a health and demographic surveillance system so has regular contacts to their former study participants. We have not completed follow-up yet, but we are confident to reach around 1,800 participants out of those former almost 2,500. Now I can assume that not everybody may know what a health and demographic surveillance system is, so just briefly outlining why we believe this is so helpful in tracing our study participants. So an HDSS has been implemented nowadays in more than 50 countries or sites across Asia and Sub-Saharan Africa, as shown on the map here on the left. And the idea of this, that this is really full population cohorts which are under regular surveillance. So at least once a year, there will be a team visiting this full population. That's why we start with a census here, so to really know how many people live in every household in that area. And then we will regularly investigate the number of births or people who migrated into that household. That's what is shown here on the bottom, as well as the number of individuals who died or left the household, so out migration. And because there are these systems established, households are well known as well as their basic characteristics. And this has really helped us to identify and still keep in touch with the households who were part of this IPTI project 20 years ago. And now what we are interested in, I already mentioned dietary practice and cardiometabolic health. So what we currently do, and this is pictures here from one of our PhD students, Marianne, whom I'm happy for that she has generously gave me those photos. We are doing anthropometric examinations here, so including bioimpedance measures, but also weight and height, mid-upper arm circumference, as well as waist and hip ratios and circumferences. We are also taking blood samples and doing analysis on site, which are basically the routine clinical analysis, such as a lipid profile, for instance, or inflammatory profile. But we are also processing the samples for DNA, for epigenetic analysis, and more sophisticated analysis looking at immunologic markers, for instance, which will then be shipped to dedicated laboratories in the European Union. And we also conduct a battery of questionnaire-based interviews, where we are in the first place interested in the dietary practices of our participants, but also basic demographic information, socioeconomic background, such as wealth or education, and other behavioral risk factors, including smoking or physical activity. So with this, I would like to conclude that on the one hand, cohort studies are very, very important and helpful if we want to identify potential causes of non-communicable diseases in Sub-Saharan Africa, because they give us the opportunity to look at the temporal relation between exposure and outcome. At the same time, we have seen in the different systematic reviews that there is still a lack of high-quality cohort studies. Either they have only short duration, they don't have biobanking, or they have quite high attrition rates. And this still is the major challenge for establishing and maintaining cohort studies in the Global South. Loss to follow-up as well as attrition here. And because of lack of infrastructural capacity, we still have to consider whether biobanking is possible, in which places biobanking is possible, and how we can enable partners in the Global South to establish their own cohort studies. Most of the time, this is due to non-permanent funding. So quite often, partners have been lucky in obtaining funding for establishing the cohorts, but then how do we fund the continuation of that and making sure we can have repeated measures to closely monitor whether the outcome develops or not. And you can see even from our example, that was the same case. So even if we are now lucky trying to retrieve and tracing a lot of participants from 20 years ago, we still don't know what happened in the 20 years between. So also we have like a blind spot here. And the potential solution for establishing and maintaining cohort studies is possibly to integrate them in existing surveillance systems, such as the HDSS systems, which I have just shown you a few slides before. So I think with this, I would really like to thank our collaboration partners who made this possible, as well as the different funding bodies